everyone. I'm Dr. Mangla and I'll be presenting on Terson syndrome. We had a patient aged 34 years old, male, a resident of Firozpur and farmer by occupation. The chief complaints of the patient were diminution of vision in both eyes, which was gradual, progressive and painless in nature. History of present illness. The patient presented with gradual, progressive loss of vision, which severely impaired his routine activities and grossly impacted the quality of life. Past history. The patient a year ago was found unconscious in his room with Glasgow Coma scale of 8, experiencing seizure. He also experienced acute respiratory failure and was developing hydrocephalus. On hospital admission, a computed tomography scan was done and angiography was done, which revealed an aneurysm in middle cerebral artery. Ultrasound Doppler was done, which revealed a thrombus in great Cephas vein. And so he went terminal of internal carotid artery, along with insertion of external ventricular drain, which was finally removed after 15 days. He was extubated with a Glasgow Coma scale of 14. The patient was diagnosed with subarachnoid hemorrhage. Once the patient was stable and regained consciousness, he complained of bilateral loss of vision, making him dependent on his relatives. Personal and family history was not significant. Ocular examination. The best corrected visual acuity of the patient in both eyes was hand movement positive. The perception of light and projection of rays were accurate. The intraocular pressure as measured by Goldman application tonometry was 16 and 19 in both eyes. Extraocular movements were full, free and painless in all cases, and no nystagmus was seen. The lids and adnexa were normal, conjunctiva was normal, cornea was clear, anterior chamber was quiet and well formed. Iris had normal color and pattern. Both the pupils were normal in shape and reaction. The lighter plexus were normal without any relative afferent pupillary defect. The lens were phakic in both eyes. When we did fundus examination, it revealed dense vitreous hemorrhage. Management, initial investigations were done which revealed a normal blood profile and viral markers. B-scan was done which revealed bilateral vitreous hemorrhage with an attached retina. The patient had subarachnoid hemorrhage and bilateral dense vitreous hemorrhage. A diagnosis of Terson's was made. On account of young age and bilateral dense vitreous hemorrhage and extreme deterioration in quality of life, a 23-gauge pars plana vitrectomy was planned. So here we were doing the pars plana vitrectomy. Initially right eye was done, followed by left eye 2 weeks later. Post-operative findings after 5 months. The best corrected visual acuity of the patient improved to 6.9, which with pinhole it improved to 6.6. The intraocular pressure as measured by Goldman application tonometry was 17 and 15. Extraocular movements were full and free and painless in all cases without any nystagmus. Lids and adnexa were normal, conjunctiva was normal with cornea was clear in both eyes, anterior chamber was quiet and well formed. Iris had normal color and pattern. The pupil had normal shape and reaction with normal light reflexes and no relative afferent pupillary defect. The lens were phakic. The fundus photograph taken 5 months post-op revealed clearing of the vitreous hemorrhage. OCT was done which showed mild diffuse edema with internal limiting folds. Discussion. Terson syndrome is a rare intraocular hemorrhage which is mostly associated with subarachnoid hemorrhage and can be seen post any brain injury. It is hypothesized that whenever there is a sudden increase in intracranial pressure, it would lead to retinal vessels rupture. The bilateral incidence is around 42 to 87.5% and occurs around 8 to 19% cases with subarachnoid hemorrhage. Screening is crucial in all the patients of subarachnoid hemorrhage and particularly those with low Glasgow Coma scale. Fundus examination is the gold standard. Management. We do a 23-gauge pars plana. Initial 3-month period of observation is done with 23-gauge pars plana vitrectomy. We can also do intravitreal injections of tissue plasminogens. Complications include proliferative vitreoretinopathy, glaucoma, epiretinal membrane formation. Factors affecting prognosis include the age, rate of pre- and post-operative complications, and neurological conditions of the patient. Thank you.
Thank you. I think it's quite straightforward with things that it's going on. But my only thing is that in the management one is that obviously in this case you would probably have to wait for some time because of the neurological deficit or the neurological clearance.
Yes, so the patient first he had to manage the neurological symptoms only post after he came
Otherwise,
out.
I don't think that it's standard practice now to really wait for so long.
Yes,
Secondly,
sir.
what is the role of tissue plasminogen activator?
So it helps in clearing of the breaking of the clots and clearing of the hemorrhage, early clearing of the hemorrhage.
But you are not used, eh? This is
No,
written
sir,
in literature.
yes, sir, yes.
ठीक है.
Okay, thank
It's
you.
quite expensive for the patient to do.
So next we have, thank